Yes, yes. So good afternoon everyone. We are coming to the next session, that is a free paper Cornea 1. And whether we have all the presenters here. The first presentation, Professor Alok Sati, he is here. No, 130. Sorry. Oh, I don't know. Sorry. I'm Dr. Which session we will get? So the first paper by Dr. Alok Sati, I think he is not here. The next paper, Anxiety and Depression in Keratoconus, Dr. Deep Shikha.
Dr. Chatterjee.
Sorry?
The presenting author is Dr. Chatterjee.
Okay, presenting Dr. Samrat Chatterjee, right sir, right sir. Yes.
Good afternoon. So I was just looking through the program book and suddenly keratoconus has become very, very important for us. The entire Cornea 1 session has papers only on keratoconus, which was probably not so around 5 to 10 years back. So I'm going to discuss another aspect of keratoconus, the impact it has on patients with the emotional, mental stress that the patient has when they are diagnosed with keratoconus. So I have no financial interest or any conflict of interest to declare. So a patient of keratoconus, when he's typically diagnosed as keratoconus, is a male patient, generally a male patient in India, belonging to either a student or a professional, age group of 18 to 25 years old and coming from a middle or upper class background. This age group of 18 to 25 years is what is known in psychosocial development as an emerging or young adulthood. And they are a vulnerable population because they are at an epoch time of their life. They are defining their life goals, appearing for exams, building up a career. Someone would have completed their career and started off with a job and starting businesses or their careers, professionals. So it's an important phase in their life. And when they are diagnosed with a disease that is said to be non-curable, would have significant morbidity, they take it very, very in a difficult way because their mental maturity is still not mature enough to deal with it. We must remember that they are otherwise an healthy individual and may be encountering ocular disease or any health related issue for the first time. So we wanted to see the prevalence of anxiety and depression in patients with keratoconus, and this was a cross-sectional study that we did in our institute. We did a sample size calculation, and we also we took ethics clearing committee clearance. So we included all patients of keratoconus who were 18 years or more and who had been diagnosed with keratoconus for at least 3 months duration. And we excluded patients with other systemic or ocular comorbidities, and also excluded patients who had recent bereavements or recent other emotional trauma not related to their diagnosis. So for measuring anxiety and depression, we used the hospital anxiety and depression scale. Why did we use it? Number one, it was designed for primary care setting, not for a psychological or psychiatry department or OPD. It can screen both anxiety and depression in a single questionnaire format. It is very easy to use, and also it is available in Hindi and has been used in other ocular diseases in India. So we included 104 patients in 8 months' time. Their median age was 25, and like a typical keratoconus profile, they were mostly males living in urban areas, and they were either students or professionals. If you look at the keratoconus profile, their diagnosis was there for a median of nearly 2 years. Most of them were either moderate or severe keratoconus. Surprisingly, very few had binocular vision impairment, and a majority of them were being treated with glasses, contact lens. Some had undergone cross-linking, and few had undergone PK or DALC. If you look at the prevalence of anxiety and depression, around 36 and 37% of patients were either borderline anxious or borderline or definite anxiety was detected, and around 77% of them had either borderline or definite depression scale score positivity. If we look who were more likely to be anxious, Patients who were coming from rural areas were more likely to be anxious. Patients who had married were more likely to be anxious. And patients who had moderate or who had severe keratoconus were more likely to be anxious than the others. And who were likely to be depressed, that was patients who were more educated were likely to be depressed. Patients who had severe keratoconus were more likely to be depressed, and surprisingly patients who had undergone cross-linking were more depressed than the others. So is the depression or the mental anxiety or mental depression in patients in keratoconus more than the normal population? It is definitely more than the normal population. If you look at normal healthy school-going or college-going students in India, the depression of keratoconus that we measured of 72 and 77% were definitely higher. And it was also higher than other ocular comorbidities like vision impairment, low vision, glaucoma, ARMD, and Fuchs corneal dystrophy. So most of the patients were either anxious or depressed, like patients from rural areas and who were less educated were probably because they could not understand or comprehend the disease very well. Patients who were married were probably more anxious because there were concerns of family welfare. Patients who had undergone cross-linking, probably this was because they had undergone an operation for the first time. They were otherwise a healthy individual and they had inadequate coping mechanisms for this. So what is the carry-home message? We should screen patients with keratoconus for anxiety and depression. Screening can be done with HADS, which is an easy tool to use. And we can improve our counseling techniques, give positive reinforcement, and help these patients in understanding a disease. And patients who are found to be frankly depressive or anxious can also probably get a psychiatric care or psychological counseling in addition. Thank you.
Was there any subjective assessment of the anxiety or a depression? Like how did you rate that, whether it was a mild, moderate or severe depression or anxiety?
No, the HADS scale has only 3 scales. Either it is normal, then borderline, if the score is between 8 to 10, and if it is more than 10, then it is frankly this thing what called either anxiety or frank depression is present. So it doesn't measure the anxiety as mild, moderate or severe. It is a screening tool. So that differentiates people who are either with the disease or they are either out of the disease. So for the further this thing, because in an eye clinic, this is what you can do, either screen of the patients, and if we found them to be, having either frank or higher scores, then you refer them to a psychologist for their further counseling, further stratification and further treatment.
That's what I wanted, like you've done a very good job, but it was just an arbitrary assessment of whether anxiety...
It was not arbitrary, because we use the HADS scale.
What all things you had taken into consideration? This patient is having a...
We took all these parameters that we discussed. I did not discuss because of constraint of time the non-significant parameters, but this is not an arbitrary this thing. The HADS is a definite instrument. There are multiple tools in psychology to assess depression and anxiety. Why we chose HADS? One, it has been designed for a primary care setting. So it need not be that we are using in the cornea clinic, it can be used in other settings also. Once you screen out the patient, then you can take these subsequent steps. Okay. Thank you.
Mic on, madam. On नहीं किया मैडम, press it. Okay.
It is this, the presentation will run here in this.
Just for the hall people, your timer isn't showing on that laptop. I urge the other speakers to be conscious of that, and you're also not telling us, the hall managers, that beep, should it come at 5 minutes or should it be at the end? So I request the judges to kindly get all those things incorporated for the benefit of the subsequent speakers who are going to present, because this is a competitive section.
Yes, Dr. Bhavana.
Yes. Good morning, everybody. And I would be speaking on therapeutic profile of human umbilical cord blood serums in ocular allergies. What we know about ocular allergies is that it is caused by hypersensitivity reaction due to specific antigens, and the related mechanisms are mainly the prostaglandins, leukotrienes mediated mechanisms. And because of that, the main therapeutic modalities range from antihistamines to steroids, NSAIDs, and to immunomodulators in severe cases. So the objective of this I'm sorry, I'll have to interrupt, I'm sorry. The presentation which was loaded was different.
What you uploaded it and what you have made modifications. So the one that I made modification wasn't reflected there. But anyway, so I don't know which ones they had.
Can you allow me to present the presentation because there is some involvement and some ambiguity in this one.
Audio visual.
So I request that I may be given this permission to present the presentation which was loaded today.
She says that the presentation what she has loaded is not there.
If you allow, let it allow.
You can yes ma'am, you can use your laptop or
Meanwhile, next person.
ma'am, if you don't mind, we can take up the next presentation till then.
May I invite Dr. Omar Rashid? Dr. Omar Rashid,
Yeah.
presentation. FP 533.
Can I check the presentation once, whether the videos are working or not? No, this is not the one which I uploaded in the morning.
Go and check it. Dr. Shivam Sharma, you please come. My FP 627.
Audio visual person, you can upload this, the next presentation.
FP 627.
Good afternoon, everyone. So, presentation title is Prognostic Insights and Genomic Landscape of Mitochondrial Dysfunction in Keratoconus. There is no financial disclosure to disclose. So, keratoconus is most common corneal ectasia, involves progressive thinning and steepening of cornea. It is irregular and bilateral and asymmetric in nature. So, the exact etiology of keratoconus is not known very well yet, but there are molecular evidences which suggest that there is dysregulation of oxidative balance and mitochondrial dysfunction in keratoconus corneas. These are some clinical signs of keratoconus: Munson sign, flesh-showing, rigidity signs, and Vogt stripe. So, oxidative stress can be of two types, like from endogenous source or exogenous source, which will lead to the generation of reactive oxygen species and reactive nitrogen species. In response to that, cell will generate lipid and nitrate peroxide enzymes and antioxidant enzymes to combat the oxidative stress, which will lead to the production of oxidative stress and oxidative damage in the cell. And the next step is activation of degradative enzymes, mitochondrial DNA damage, or corneal thinning if not properly combated with this oxidative stress. So, during the oxidative stress, which I described in my previous slide, the mechanism involved in keratoconus cornea is there is a production of abnormal antioxidant and peroxidation enzymes, due to which there is accumulation of reactive oxygen species and reactive nitrogen species, which will lead to oxidative damage. And inside the cell, there will be a reaction with the proteins and phospholipids, which will convert them to degradative enzymes. There is mitochondrial DNA damage, apoptosis, and corneal thinning. And this process will go on, and there is more accumulation of reactive oxygen species and nitrogen species because these are not eliminating by proper enzymes, production of proper enzymes. Now, whereas if we talk about the normal cornea, there is a production of proper antioxidants and lipid peroxidation enzymes which will eliminate this oxidative stress. So, there is no oxidative damage or stress inside the cell, and the cell will function normally. These are some literature evidences which shows that there is oxidative stress in the keratoconus corneas. So, our aim is to, we did whole mitochondrial DNA genome sequencing of blood and tissues from keratoconus patients. We also did ultrastructural analysis to look for the morphology of mitochondria in corneal tissues, and then we did expression level check of oxidative stress genes in corneal tissues of keratoconus patients. We recruited total 20 keratoconus patients, and we collected blood and cornea from same patients. Corneal tissue was also processed for transmission electron microscopy, and then we did quantitative real-time PCR to assess the gene analysis of oxidative stress genes. These are the demographic details of these 20 keratoconus patients with male preponderance in the study. 70% of the patients were male, and these majority of the patients, like more than 70% of the patients, have the habit of eye allergy and eye rubbing. There is 35% of the patients have only family history of keratoconus. Coming to clinical phenotypes of these patients, the Munson sign and Vogt are present in majority of the cases, more than 70%. Whereas Plastering is present in 55% and Rejuti sign is present only in 15% of the cases. The thinnest pachymetry recorded was average is 415.86 plus minus 85 microns. Now, coming to ultrastructural analysis results. So, the mitochondrial morphology of normal cornea, which shows proper and healthy mitochondria inside the cell or epithelial layer, the cristae and the double layer mitochondrial structure was properly identified. Whereas if we see in the keratoconus corneas, there is hollow, swallow mitochondria were recorded. All the mitochondria were either hollow or swollen in nature. They are cylindrical in nature, but not proper healthy mitochondria were identified or recorded in the epithelial cells of keratoconus tissues. So, it confirms that there is a mitochondrial damage at morphological level. Next, we go for DNA isolation, followed by their whole mitochondrial genome sequencing. So, we found out that there are variations in all the samples. Total more than 500 variations were found out. Majority of them was transition type of variations like adenine to guanine or guanine to cytosine. So, majority of the variations, these are the highlighted one variations which are repeated in many of the samples, like variation at position 4769, adenine was converted to guanine in 13 samples of both blood and tissues. Similarly, at position 15326, adenine again converted to guanine in 12 and 10 cases of blood and tissues. And we are doing mitochondrial sequencing on more samples to conclude these variations at protein level, if there is any amino acid change or protein changes in this keratoconus corneal tissues. Then we also isolated RNA from these samples to do the quantitative real-time PCR for analyzing and identifying expression of these genes. So, in our samples, only PRDX6 gene was upregulated in majority of the cases, whereas all the 3 genes were downregulated. Then we correlated these genes with clinical parameters. So, eye rubbing and Munson sign was correlated strongly and statistically with PRDX6. Again, SOD2 was correlated with eye rubbing, Munson sign and eye atopy. Similarly, NRF2 and GPX4 was also correlated strongly and statistically with Munson sign, Vogt and eye atopy. So, this is the first of its kind of study to provide information of mitochondrial DNA mutations in Indian population, and majority of the variations are novel and rest of them variations are reported in numerous ocular and systemic diseases. We also found the damage and irregular morphology of few mitochondria in corneal tissues and keratoconus patients. mRNA expression levels suggest that there is downregulation of antioxidative genes, and this again indicate there is mitochondrial DNA damage. So, we will recruit more patients to evaluate mitochondrial DNA as a genetic risk factor in contributing and progression of keratoconus. Thank you.
What is the inciting factor for mutation?
Sorry?
What is the inciting factor for mutation?
We did, these are not proper mutations yet, these are just variations. If these were concluded to protein change, then we can call it for mutations and it will come to the progression or development of keratoconus. So we will say that these are markers.
Is it a cause or a effect?
Sorry?
Is mitochondrial mutation is a cause or effect of keratoconus?
No, it can be cause or effect. It will result in cause and the progression both, maybe. Thank you.
Mr. Shivam, you are an AIS member?
No.
Because it's labeled as Mr. Shivam, so you are a ophthalmologist?
No, not basic science, basic research.
Okay.
Thank you.
Thank you. Bhavana madam, you would like to present?
Timer?
Start the timer.
वो नहीं रहेगा शायद लैपटॉप में.
No, they exit it from this side. No?
Okay. I start. So I would be speaking on the therapeutic profile of human umbilical cord blood serum in allergic eye diseases. It was a pilot study which was conducted at AIIMS Bhopal. We don't have any financial disclosures to make. What we know about is that ocular allergies are because of hypersensitivity reaction and exposure to specific antigens. Particularly, the mechanisms involved are prostaglandins and leukotrienes mediated. So the treatment modalities are antihistamines, mast cell stabilizers, steroids, NSAIDs, and in severe cases, immunomodulators or cyclosporin or tacrolimus may be given. What was not known till now was that the research question in this study was that whether any other treatment modality which is responsible for causing ocular surface restoration would be helpful in treating patients of ocular allergies. So we thought that the umbilical cord blood serum could be helpful in such cases because it has got high concentration of growth factors, the EGF, TGF beta and substance P. It helps in proliferation, differentiation and also maturation of epithelial, ocular surface epithelium and has got a very strong anti-inflammatory action. So with this objective of the study was to evaluate the efficacy of UCBS in ocular surface restoration, whether there is any improvement in visual functions based on the objective and subjective parameters, and what was the overall best predictor of clinical improvement in patient which was treated with UCBS. The sample size calculation was done based on this study with the effect size of 0.25 and the power considering to be 80%. The sample size was found out to be 23. We did a detailed ophthalmic examination and grading of all ocular allergies were done. Patients were treated, classified into severity grades, and all the such patients were included. The exclusion criteria comprised mainly of any infection or posterior segment anomalies. It was a prospective randomized clinical study in which total 40 eyes were evaluated for a follow-up of minimum of 3 months. The cases were randomized into 2 groups. The group 1 was UCBS and group 2 was autologous serum. The randomization and blinding was done into 2 blocks, as I said, and patients were evaluated by single blinded observer with appropriate statistical indices. We harvested UCBS through uncomplicated cesarean deliveries after the triple H test. The primary outcome measure was improvement in the severity grade and the eye sensation score. Secondary outcome was whether the resolution of the intermittence or the persistence of symptoms was there, and also the improvement in visual acuity. The demographic pattern was the most common age group was up to 19 years. Most of the cases were bilateral and there was slight male preponderance. We graded, we made the 2 groups homogeneous in terms of both symptoms and severity grade. So this homogeneity would not be, by getting this homogeneity, we excluded any confounders in both the groups. Coming on to the results, we found that response to treatment at 1 and 3 months in UCBS and AS, that is group 1 and 2, was significantly better in UCBS as compared to the AS group. That means at 1 month and at 3 months, almost all patients resolved with UCBS, whereas just 60% in group 2. However, in severe grades of ocular allergy, there was a difference, but it was not statistically significant. The subjective improvement was measured with the ARIA classification, and we found that the subjective improvement with reference to itching, redness, disabling visual symptoms which is impairing with the school or official work, we saw again that at 1 month and at 3 months it was significantly better in UCBS as compared to AS, respectively of 100 and 60%. Eye sensation score at 3 months again was seen in comparison to pre-treatment level. We can see here that the eye sensation score begin with was present just in 12 patients in mild and moderate variety, whereas after completion of the therapy at the 3 months, almost all patients had eye sensation score reduced to 1. Whereas in group 2, it was just 16 and 4 patients in moderate and severe variety. The statistical significance was seen for all objective and subjective parameters, and we found that the statistical significance was seen in eye sensation score in mild ocular allergies and moderate ocular allergies. It was not significant in visual acuity and in severe disorders. The overall best predictor of improvement was the eye sensation score and response to severity grade. There have been many studies which have been conducted on UCBS on various disorders like dry eye disease, on persistent epithelial defect, on neurotropic keratitis, and all have reported that it has got a good impact on the ocular surface disorder. These are some clinical pictures of improvement seen in the group 1. And the conclusion that this study pioneers in showing the efficacy of UCBS, mild OA respond well as mild and moderate respond well as compared to the severe varieties, and it can be considered as an alternative where you want to give for long-term steroids, and it helps in ocular surface restoration, both objective and subjective parameters. The overall best predictor of improvement was eye sensation score and response to severity. Thank you very much. These were my references.
So you conclude that umbilical cord serum would be better than autologous serum?
Yes.
At least in a mild to moderate allergic disorders?
Yes, and it can be taken as an adjunct or also as an alternative to topical steroids, where you don't want to give it for a longer period of time, in severe cases also. So that was the conclusion of the study.
And how do you, like, in how many days it could be used or something once you procure or you get a umbilical cord serum?
For all these are uncomplicated cesarean delivery. So at the first reporting of the ANC to the hospital or to the doctor, we conduct the triple H test, and including the syphilis also, and then at the time of delivery we do. So we have got a minimum window period of 3 months at least, and then we take the UCBS, prepare it, process it, and then you can use it. There is no preservation for that.
How long you can use that once you had got it?
Yes, it is preferred to be used within 7 days and to be kept in refrigerator at 20% UCBS.
Thank you. So Dr. Omar Rashid, right?
Yeah.
Yeah.
So my presentation today would be on manual cares with or without cross-linking for keratoconus. CARE stands for corneal allogenic intrastomal ring segments. It was developed in 2016 by Dr. Susan Jacob. Corneal stroma from donor cornea used to form strip resembling intrastomal corneal ring segments. This was mostly done by creating intrastomal tunnels by femtosecond laser. Parker et al. In 2021 published an article in JCRS where they used manual corneal separators and microkeratome system to create intrastomal channels. They concluded that manual CARES implantation is technically possible and may be a viable option where femtosecond is unavailable. Our technique is somewhat similar to what was described by Parker. However, we do not employ a microkeratome suction device to stabilize the globe. We rely on a modified corneal dissector, which we name as OR corneal CARES dissector. It has sharper blades and a bulkier diameter to create greater torque. So on the left hand side we have the trifine used by Parker, and the right hand side is the one designed by us. So this is based on this equation of creating a greater torque by just increasing the diameter of this trifine, and we have to amount less force in creating so. So ours was a prospective case study, and the aim was to study the topographic and visual acuity changes after manual CARES combined with or without CXL. So keratoconus with minimum pachymetry of 370 microns were included. 1 mm wide CARES segments were prepared using Jacob CARES trifine. Peribulbar block was given. Arc length of channels was masked using a Mendes gauge in 6 mm optical zone. Partial depth incision made using partial depth blades, that is 300 microns, and 1 mm interstomal channel created using OR dissector, and the incision was closed with 10-0 nylon. So this is the part where we create these segments, care segments. We remove the epithelium, endothelium on both sides. And here we are using a simple trifine. This is a button which has been previously used for a 7.5 mm optical keratoplasty. And here we have made a uniform 1 mm thick strips. We stain it with trypan blue and divide it in 2 segments. And they can be left over a Mirocell sponge to dry, or else they can be used in a non-dehydrated state as well. Here we are marking a central 6 mm zone using a trifine, and using a Mendes gauge we create the arc length. This is a partial depth incision 300 microns, creating a channel pocket, and this is our channel creation using the modified dissector. We have to be parallel to the iris plane all the time, and these are the pre-cut strips. And you can see these can be incorporated into these channels using reverse Sensky hook. We trim it to a proper length and close the wound with 10-0 nylon. So post-op regimen is like steroid antibiotic combination 4 times a day for a week and then tapered over a month. Tear substitutes SOS, and we usually remove sutures in 2 weeks time. So these are the results. You can see the cylinder has gone down from -10 diopters to -4.85. Similarly, this is showing a intrastromal care segment. Again, we can see good refractive results here, cylinder coming down from -5.5 to 2.25. So 24 eyes with keratoconus were treated, 16 cases were standalone cases, 8 were combined with accelerated CXL. Mean follow-up was around 10 plus minus 3.5 months, and significant improvement was noted in uncorrected visual acuity and corrected visual acuities for distance. SIM-K keratometry, astigmatism and steep keratometry all showed a decrease in all cases. All cases remained stable in post-op period and no major complications occurred. So the clinical implications are, this study proves that efficacy of cares in treating keratoconus as shown in previous studies. Manual cares can be safely performed by every corneal surgeon without investing in expensive and high-end equipment. Learning curve is not so steep. With further modification and refinement in instrumentation and technique, a standard protocol can be formulated to make the procedure more consistent and predictable. Thank you.
Did you combine this with the cross-linking?
Yes, not all cases. There were many cases, like 8 cases were such where previous cross-linking was done. So in those cases, we just did standalone cares. Many cases were combined. We first do a cares, then remove the epithelium, and then proceed with the cross-linking.
What is the minimum thickness of cornea you are taking?
What we are taking is 370 microns. We are not going below 370.
Excluding epithelium?
Including epithelium.
Including.
And what was your cutoff for a topography? Like how steep the cornea, maximum steepness of cornea that you had taken for a cares?
So usually we didn't take cutoff for keratometry. Our cutoff was very thin corneas. Suppose if the thickness was less than 370 microns, then we didn't go for a.
And in case if the thickness was 410 and if the K1, K2 were somewhere in the range of 58, 64.
Yeah.
So you had like
yes,
still.
We have done those cases.
And any cases of you had a epithelial ingrowth or something?
No, not yet. The mean follow-up period was around 6 to 12 months. Till now, we have not seen any cases of epithelial ingrowth.
And how long you continue with topical steroids?
4 weeks.
So after 4 weeks, you're discontinuing everything.
Yeah.
Good. Okay. Thank you.
Thank you.
Thank you.
One question is there for you. One question is there. You checked about the astigmatism. Checked about the astigmatism.
Yeah.
And what is the result of?
We checked both using a topography as well as.
Now, what is the result you found? That I wanted to know. Regarding astigmatism.
Yes,
of the case.
the SIM-K keratometry showed a mean decrease in 4.6, astigmatism showed a decrease in 5.1 diopters, mean.
Okay.
Yeah.
So we have the next speaker, Dr. Rashmi Deshmukh.
Thank you. At the outset, I'd like to thank AIOS for the opportunity to present our work. We all know that keratoconus is a bilateral but asymmetric disease. And a lot of times we see that only a few eyes progress and not all of them progress. Even in the same individual, one eye can remain stable and the other eye keeps progressing. This is often seen, but the cause is still unknown. So we ask the question, why do some eyes progress while others remain stable? And the purpose of this study was to analyze the biomicroscopic changes in progressive keratoconus and correlate with biomarker changes to understand pathophysiology of progression better. So we included patients more than 18 years of age with bilateral keratoconus who had a unilateral progression on follow-up visits. And we excluded patients who had previous ocular surgeries, allergic conjunctivitis or vernal keratoconjunctivitis, or patients on topical medications, patients who were using contact lenses, and patients with hormonal disorders or any hormonal therapy. The sample size was calculated to be 15 in each group, and we included both eyes of the same individual to make sure that the risk factors were similar. So in the same individual, one eye was stable, other eye was progressive. 20 patients with 20 stable eyes and 20 progressive eyes consequently were included. And all patients underwent slit lamp evaluation, corneal topography, confocal microscopy, and tear sample collection on baseline as well as the follow-up visits. Confocal microscopic image was analyzed using automated CC metrics software, which analyzed the image and annotated it to calculate the nerve branches, branching points, and the main nerve fiber, and gave the parameters automatically. Tear sample analysis was done by collecting the tears with Schirmer strips and storing them in Eppendorf tube at -80 until it was seen which eye was stable and which eye progressed. Further, they underwent BCA analysis and ELISA was done to calculate the biomarkers. So coming to the results, on confocal biomicroscopy, we saw that there were significant changes at baseline between the stable eyes and the progressive eyes in nerve fiber density, nerve branch density, nerve fiber length, and the total branch density. These are the representative image of a stable eye and a progressive eye. We did not see any difference in the keratocyte density in the anterior stroma, middle stroma, or the posterior stroma. On follow-up visits in stable eyes, we saw that there was no significant difference between the baseline visit and the follow-up visit in stable eye. But in a progressive eye, we saw that the nerve fiber density, nerve fiber length, and the total branch density continued to reduce significantly. Then we further performed a correlation analysis between the tear biomarkers which we had seen with these confocal features that we were seeing between the two eyes. And we saw that there was a strong correlation between the SBNP features with interleukin 2, 21, and CCL2. To simplify the previous slide, the correlation analysis showed that the interleukin 2 and interleukin 21 had a significant difference in progressive keratoconus with CTBD, but this was not seen in the stable eyes. Similarly, CCL2 was significantly different in the progressive eyes when it came to correlation with nerve fiber density, total branch density, and nerve fiber length, but this was again not seen in the stable eyes. So we saw that there was a significant difference in the nerve parameters and tear cytokines in progressive eyes as compared to the stable ones. So we already know that there is a confocal microscopic change which is seen in normal eyes as compared to keratoconic eyes in terms of subbasal nerve plexus features. And we have also seen that some inflammatory biomarkers have been identified which are seen in keratoconic eyes as compared to eyes which are normal. So we know that inflammatory cytokines are increased in keratoconus as compared to controls. But in this particular study, we looked at the biomicroscopic changes and combined them with biomarker changes in keratoconus, where one eye is stable and the other eye is progressive. And we came up with specific biomarkers which were seen only in progressive eyes and not in stable eyes. So what we already know is that keratoconus is bilateral and asymmetric, but not all eyes progress at the same rate. Confocal microscopic changes in nerves and keratocytes have been described in keratoconus as compared to normal eyes. But what our study adds is that there is a significant difference in the nerve parameters in stable versus progressive eyes in keratoconus, not seen in keratocyte density. And interleukin 2, 21 and CCL2 have a role to play in these structural changes and could be targeted in future to arrest progression. Thank you.
So, like after analyzing this study, how we are going to help our patients? How would we, the eye which is progressing, or at times if we are seeing a patient where one eye is progressing and other eye is not so progressing,
Because
how would it change our management?
that is what we have seen, that we've identified the markers now. Now we will have to find a treatment to target these markers, isn't it?
So you are concluding that these were the markers which were raised in the affected eye or the eye which was showing the progression.
And it is causing structural changes as well. So that is why we have done a correlation. That not just that the markers are increasing, but it is also causing a structural change which can be identified on confocal biomicroscopy, which is showing that there is a difference between the two eyes. Because the individual is same and the rest of the risk factors are going to be the same.
But they had been on some sort of any immunomodulatory, some steroids or anything?
No, we've
right?
excluded
Not
all
really.
of that. That was the exclusion criteria that I had shown.
Okay.
Thank you.
Thank you.
Next is
Dr. Shivangi Sharma.
Good afternoon, everyone. This is not moving. Excuse me. Okay, can we reset the timer?
Can you reset the timing?
Okay. Good afternoon, everyone. The title of my paper is Analysis of Specular Microscopy, Pre- and Post-Corneal Collagen Cross-Linking in Patients of Keratoconus with Thin Corneas. The purpose was to evaluate the corneal endothelial changes following CXL for the treatment of keratoconus in patients having corneal thickness between 400 and 430 micrometers. It was a prospective non-randomized clinical study with a sample size of 32 eyes. The study population was patients with keratoconus having minimum corneal thickness between 400 to 430 micrometers undergoing standard CXL by the Dresden's protocol. Patients having corneal scar pachymetry values less than 400 micrometers and more than 430 micrometers, history of recurrent erosions, connective tissue disorders, or previous history of viral keratitis were excluded from the study. Specular microscopy was performed pre and post CXL to assess the endothelial cell density, the coefficient of variation, and the percentage of hexagonal cells. Follow-up was done on day 5, 20, 45, day 60, and day 180. Specular microscopy was done in each visit. Coming to the results, the baseline endothelial cell density was 2908, which exhibited a decline following CXL. The 6 months follow-up value was 2847 with a mean difference of 60 cells per millimeter square. We can see the comparison of endothelial cell density across the different time points. The mean baseline coefficient of variation was 28.69. It exhibited an increase following CXL, and we can see the comparison of coefficient of variation across the different time points. The baseline percentage of hexagonal cells was 58.22 plus minus 5.99 percentage. In this figure, we can see the comparison of percentage of hexagonal cells across the different time points as it exhibited a decline following CXL. In my study, the endothelial cell density exhibited a decline, the coefficient of variation increased, and the percentage of hexagonality decreased at the end of 6 months period. However, no harmful endothelial reactions were noted in our study. A study was conducted by AIOS et al., which showed that the average endothelial cell density in the Indian population in the age group of 20 to 30 years was 2,782. The recorded values in our study fell within this physiological range. Similar studies were conducted by Vinciguerra P. et al., Quinones G.D. et al., and Goldich Y. et al., which showed a 4.9, 3.6, and 7.5% decline in the endothelial cell density post-standard CXL. In our study, there was a 2.09% decline in the endothelial cell density. A study was conducted by Gues et al., which showed that the mean endothelial cell density decreased till 6 months following CXL, and thereafter it stabilized. A study was conducted by Badavi et al., which showed that at the end of 3 months period, there was a 6.7% decline in the endothelial cell density, which gradually improved, and at the end of the 12 months period, it increased towards the preoperative values. In our study, the endothelial cell density exhibited a decline over a duration of 6 months. Nevertheless, we anticipate that the endothelial cell density will continue to stabilize with regards to the results of the studies mentioned above. Goebbels et al. Did a study which showed that more severe the stage of keratoconus, lower will be the endothelial cell count and higher will be the coefficient of variation. In our study, the reduction in the endothelial cell density may be influenced by other factors as well, such as the physiological effects of aging and the pathological implication of the disease on the endothelial cells. Further long-term trials are warranted given the possible significance of the procedure's current effect on the corneal endothelium. The clinical implication is that specular microscopy should be done routinely in keratoconus patients having minimum corneal thickness between 400 to 430 micrometers prior to them undergoing standard CXL. Patients undergoing standard CXL should also be put on long-term follow-up post-standard CXL. To conclude, my study recorded a decline in endothelial cell density, increase in coefficient of variation, and a decline in percentage of hexagonality in keratoconus patients till a 6 months period after standard CXL. These are my references. Thank you.
Is the study adding to the newer knowledge, because this is all that we had been knowing? We are doing a specular microscopy after all CXLs, and similar to what the previous studies are saying, CXL, if done in a proper residence protocol, it doesn't cause any endothelial cell loss, or it doesn't cause any endothelial loss as such. So how your study is adding to our knowledge?
So in the studies which were conducted previously, the decline was noted in the endothelial cell density, but it was not statistically significant. In my study, it is statistically significant. And in many places, specular microscopy is not conducted routinely in patients who are about to undergo standard CXL. After this study, even those hospitals can incorporate this into their policy and start conducting specular microscopy and keep these patients on a close long-term follow-up.
Ideally, specular microscopy has to be done before we are undertaking any sort of a CXL. If it's not done at some places, that might not be the right idea. Okay, your study, it goes in tandem with what the previous studies have shown.
Yes, sir.
Yeah, thank you. The next speaker, Dr. Gagandeep Kaur.
A very good afternoon to all the delegates present over here. I am Dr. Gagandeep Kaur, and I will be presenting today on the topic assessment of changes in high order aberrations that are observed following corneal CXL in keratoconus patients. So in introduction, we all know that keratoconus is a progressive ectatic non-inflammatory disorder which causes progressive thinning and steepening, and cornea becomes conical. And how does it affect? Who does it affect? It starts typically at the age of puberty, and usually the process continues for 10 to 20 years until the progression gradually stops. The ocular allergies, ocular rubbing, atopy, Down syndrome, they have the higher incidence. And what problems does it cause? The thinning and protrusion causes irregular astigmatism, progressive myopia, and high order aberrations also. And a consequent visual function is lost. What are HOAs? The aberrations are phenomena which occur when light rays from a given point object fail to form a single image point, and this leads to degradation of the quality. And what do we usually do for keratoconus in conservative? By controlling the rubbing and spectacle correction, and surgical CXL, ICRS, corneal transplant, etc. And in CXL, it is a therapeutic procedure which basically mitigates the progression, and it forms the equivalent bonds, thereby making the cornea rigid. And in our study, we want to know that how does it affect the HOAs. Our aim is to study the pre and post-operative total high order aberrations, horizontal coma, vertical coma, and spherical aberrations, which are third and fourth order respectively. This is a retrospective study of 53 eyes of the patients between 9 to 25 years of age who were the patients of progressive keratoconus and who underwent corneal collagen cross-linking between 2023 and 2024. The corneal total vertical coma and horizontal coma, trefoil and spherical aberrations were taken, and the data from the pentacam as well as the eye trace was taken at baseline at 6 months post-operatively. All surgeries were performed by a single experienced surgeon. The inclusion criteria was all the consenting patients and the patients who had progressive keratoconus with thickness of more than or equals to 400 micron. And in exclusion, we had any active ophthalmic inflammation, any herpetic keratitis, clinical history, pregnancy, previous ocular surgery, or severe dry eye disease, or any patient with autoimmune disorders. In results, in 53 eyes of 32 patients, the post-operative 6-month data was as follows. In aberrometric outcomes, we had mean pre and post-operative total HOAs were 2.47 and 2.144, and mean pre-operative and post-operative spherical were 0.172 and 0.117. The bar graphs are shown on the side of the slide. In pre-op and post-operative, vertical coma were 0.541 and 0.477. And mean pre and post horizontal coma were 0.204 and 0.169 with the bar graphs shown on the side as well. Trefoil were 0.064 and 0.039 in pre and post operative data that was collected. Overall, a significant reduction was observed in all, that is the total HOAs, spherical aberrations, vertical coma, horizontal coma, and trefoil. So in discussion, Stephen Greinstein et al. And Ahmad Abdul Al-Karimi et al. And Mohammad Naderan et al. All of them conducted the similar studies with the objective of evaluating the high order aberrations after the CXL, and all of them had the similar results as we, although they studied more variables in correlation with this. Adam Muzik et al. Also had the similar experience in their study, except that not a significant reduction in spherical aberration was observed in their study. So in conclusion, the finding of the study demonstrated a significant decrease in corneal aberrations, and ocular aberrations play a key role in influencing retinal image quality. These results suggest that improvement in high order aberration profile is one of the mechanisms among many other contributing factors by which corneal collagen cross-linking enhances the visual function in ectatic corneas. Thank you.
How did you manage those aberrations?
Ma'am, this was just an observational study. We did not manage the aberrations. We just observed pre and post operatively what was the effect.
So if the study, how you are going to apply clinically, how you are going to help your patients?
So this is just a study which shows us that C3R, although we all know by literature that it halts the disease, progression, but in some studies we also know that visual acuity also is improved. So what are the other factors that are being affected by CXL? So this increases our knowledge in that field and helps, and then probably further studies will be more helpful for us to go in that direction.
What I would suggest is ki in case if or like say that in case even if the your pachymetry remains same or your astigmatism remains same, still some patients might have a better visual acuity, might the quality of vision might improve if not the quantity. So in that way your reduction in higher order aberrations might have helped the patients.
So, but for that we need to study further in correlation with is it decreasing independently or in correlation with the topometry or etc. Or is it independent? That it will be more helpful, I think.
We're going to do topography, in case if you're managing keratoconus, that becomes.
But we in this study we just studied the abrasions individually. We did not study them in correlation with topography, which we plan to expand this study further on, and that will be more helpful for us, I think.
And all abarometric measurements were done on a pentacam.
And eye trace also, but if the measurements were taken on pentacam, and post-operative was also done on the same machine, whichever was taken.
But ideally, if you're studying abarometry or something, you better have a abarometer rather than just getting it done on a pentacam.
So that's why most of the cases were measured on the eye trace, that is the abarometry.
Okay, thank you.
Thank you, sir.
Next speaker, Dr. Pranay Shetty. Pana Shetty, sorry.
Good afternoon to one and all present here. Today I will be talking on the topic, are all thin corneas indicative of keratoconus? So as we know, thin corneas are considered as challenging cases in refractive surgery, and at least 12% of all our refractive candidates may present with the corneal thickness of less than 475 microns. So what is the literature says? What is the best option available with us? ICL is considered one of the best options, where it corrects the corneal error, it corrects the refractive error in thin corneas as well as corrects a higher refractive error also. But there are certain disadvantages, for which are there any other laser refractive surgeries to help us correct the thin corneas of their refractive power. So literature also states that PRK is considered one of the safest procedures for thin corneas, but there are chances of iatrogenic ectasias. That is seen most commonly if there is any preoperatively subclinical keratoconus present. So, but how do we identify this subclinical keratoconus? That has been remain a challenge since eons right now. So that is where the knowledge gap persists, because we just see at the topographies and not at the corneal architecture. So we took this study forward, and first we looked at, are all thin corneas considered unhealthy or pathological? So, we took 200 eyes were studied with the corneal thickness of 450 to 490 microns, who were highly motivated for refractive surgery and were divided into group 1 and group 2. Group 1 containing of thin corneas with normal topography, whereas group 2 was thin corneas with abnormal topographies. They underwent a clinical evaluation of corneal topography and corneal biomechanics, and the corneal architecture was studied with the help of PSOCT. Now, PSOCT is an in vivo imaging device that helps in identifying the collagen orientation and density with the help of corneal bifringence principle. So it gives us the phase retardation, which helps us to assess the corneal thickness. As you can see, there is a reference map and also the patient phase retardation maps, which help us to show that the collagen density and orientation. This is one of the first machines to give even the Bowman's thickness. So now let's look at the methodology once again. So group 1 was normal topography, group 2 abnormal. When we look beneath into the architecture, we can see in group 1 the corneal collagen and orientation with reference to the reference phase retardation was good, whereas it was poor in group 2. Similarly, we also compared the biomechanics, that is SPA1 and CBI, and saw that the same theory was continuing, that is group 1 was stronger, whereas the group 2 was not that strong and was tending towards the subclinical keratoconus. The same thing was shown by our phase retardation by PSOCT. Coming to the AI grading done for keratoconus by our PSOCT, we have seen that in the AI scoring also, group 1 showed lesser incidence of the subclinical keratoconus. So coming to the second question now, is it safe to perform PRK surgery in non-keratoconic eyes that are thin? So our methodology, again we involved 40 eyes who underwent the surgery, and on a 3-year follow-up we saw that all the patients, none of them showed any regression of power. All of them presented with 20/20 vision, and the coefficient of variation was 0.94. There was no ectasia seen in the topography maps. Even in the phase retardation, it was a healthy, good collagen. and even the AI scoring showed that they were healthy. There was no incidence of subclinical or any incidence of keratoconus. So I would like to tell everyone like a takeaway home message that PSOCIT, you have to look beneath the topography. Topography is not everything. You need to look beneath how is the collagen, how is the architecture. That is what is the defining part of subclinical keratoconus. It's not wrong to do PRK, but you need to identify subclinical keratoconus to stop the incidence of ectasia. Thank you.
Did you correlate anything with the posterior corneal elevation in these patients?
So, no. So, posterior corneal elevation was kept below 17 microns. So, any patient that was considered already keratoconus was not taken into the study.
Okay, thank you.
Thank you.
Dr. Malati M.
Dr. M. Malati. Next is Dr. Deepthi.
Good afternoon, everybody. At the outset, I would like to disclose no financial interest. So, as we already know, haze is a dreaded long-term complication, and despite the use of MMC, there is still a 3.2% incidence rate currently. So that brought us to asking why is there a haze despite using MMC. So we scoured through the literature and we found that TNF-alpha and interleukin-11 were responsible for pre-existing inflammation and maybe one of the causes for
Okay. Yeah, restart. Yeah. You reset the timer also. Reset the timer also.
So I would like to declare no financial interest. So as we already know that PRK haze is a dreaded complication seen post PRK, and despite there have been many advancements, in spite of using MMC, there is still a 3.2% incidence rate. So that brought us to the question, why is there haze despite using MMC? And we scoured through the literature and we found that TNF-alpha and IL-11 are the two most important biomarkers that are implicated in post-PRK haze. So that brought us to these three important research questions. If we have methods to measure inflammatory markers, are there any surrogate markers that can reflect inflammation, and are there any drugs that are available to target these inflammatory biomarkers? So we came up with a proprietary tool, the BioM Pathfinder kit, which measures about 8 biomarkers. So the tears are measured with the Schirmer strips and are eluted, and we place it in this cartridge which has about 32 wells, and it takes about 90 minutes for the analysis to be done, and we come up with a report that is seen like so. So this has the bottommost part, it tells us the AI-driven map, which gives us, which tells us what percentage of patients are, dry eye control, or if the patient has any subclinical inflammation. It is like any other CBC report, and the reports are received in 90 minutes. So we did the methodology, we did our study under the two types. So first one was the observational study where 50 patients undergoing PRK were enrolled, whose preoperative tears were collected, and amongst those 18 patients who had haze were identified, and those patients' inflammatory biomarkers were analyzed using the kit. And in those patients we found out that there were higher levels of TNF-alpha, IL-6, MMP9 and IL-17. So we found out that in those patients who had lower amount of TNF-alpha, it correlated with minimal keratocyte activation on confocal, as opposed to a combinatory biomarker reports, that is higher levels of TNF, MMP, IL-1 beta and IL-17 had higher keratocyte activation. That correlated with increased myofibroblast activation on confocal. Even clinically, it correlated with higher amount of haze formation in those who had a higher amount of combinatory inflammatory markers. So that brought us to the second question, if it is possible to reduce the incidence of haze with targeted pre-treatment. In this second type, the interventional study, what we did was we enrolled 1,050 patients with similar refractive error. In those patients who had higher levels of inflammation, that is about 355 patients who had, they were randomized into two groups, that is group 1 and group 2. Group 1 received a non-targeted treatment and group 2 received a targeted treatment. And they underwent PRK after 1 month. And the incidence of post-op haze was measured by using Fante's grading, and it was recorded 3 months later and was correlated with the pre-op TR biomarkers. So we found that those patients with a higher level of IL-6, TNF-alpha, IL-1 beta and IL-17, they responded well to procedural therapy and sodium hyaluronate with Trehalose combination. And in our results, we found that in group 1, that is those who received a non-targeted treatment, had lesser amount of haze as compared to group 2, which received targeted treatment, and in those patients we found that there was a reduced amount of haze. So what happens if there is no biomarker kit? How do we do, are there any surrogate markers that serve as indicators of inflammation in our day-to-day clinic? So we found that these surrogate markers like meibomian gland loss, lesser TBAT, higher OSTI, contact lens intolerance and irregular epithelium were the 5 surrogate markers that can be used as inflammation. And there's already a pre-existing literature that says that if more than 2 of these criteria, that's inclusive of OSTI, if it's increased, it correlates well with higher TNF-alpha and IL-17. And if more than 3 criteria are present, it correlates with TNF-alpha, IL-6 and IL-17. And if more than 4 criteria are met, then TNF-alpha, IL-6 and IL-17, IMMP9 are all increased. So we have bridged the gap between the tier inflammatory biomarkers, if it is increased, and how we can bring it to the clinics on a day-to-day basis. So to sum it up, if there is the basal inflammatory threshold is higher and we perform a cross-linking or PRK at that point, we come across suboptimal results in the form of corneal scarring, poor nerve regeneration and irregular epithelial healing, as opposed to if we treat them pre-operatively with a targeted treatment. Then we perform a refractive surgery, then the outcomes are much better. So in conclusion, TNF-alpha is an important biomarker for predicting haze, and targeted biomarker therapy, it effectively lowers the risk of haze and scarring. But until we have biomarker kits, surrogate markers are useful, and that pre-treatment will help us to reduce the level of biomarkers before we proceed with any surgery. Thank you.
Thank you.
Thank you, sir.
Thank you.
Dr. Sanja Sirista.
Okay, good afternoon. My presentation topic is therapeutic penetrating keratoplasty in pre-COVID and COVID period. According to the national survey done in 2015 to 2019, corneal blindness was the major cause of visual impairment in India, and infectious keratitis was the primary etiology of it. And therapeutic penetrating keratoplasty was done for majority of these cases, which was an emergency procedure. COVID-19, as we have all been through it 5 years back, we are all aware about the impacts it has made in every sectors of our lives. It has also impacted eye banking and corneal transplantation practices. It has exacerbated pre-existing issues in eye banking, such as decreased donor cornea availability and logistical challenges, and which required urgent adaptation to new protocols. Our study population, in our study, we included patients aged 14 years and or above who underwent TPK due to perforated corneal ulcers, non-healing ulcers, or ulcers involving the limbal or scleral areas. Our study duration was divided into pre-COVID period and COVID period. Pre-COVID period lasted for 7 months from August 2019 to March 2020, and COVID period lasted for 24 months from April 2020 to March 2022, and it was a retrospective hospital-based comparative study.
In a total of 121 TPKs were performed during this study, 30 during pre-COVID and 91 during COVID period. There were no significant differences seen in age and gender, and as we can see in this table, the most common indication for TPK was non-healing corneal ulcer followed by perforation. So this table and the bar diagram shows the donor cornea characteristics. In this first bar diagram, we can see that the uses of MK media, which is the short-term storage media, decreased during COVID period, and cornicel and glycerol media, that is the intermediate and long-term storage media respectively, it increased significantly during the COVID period. And during the COVID period, the retrieving the cornea increased even after 12 hours of the death. However, there were no significant changes seen in the endothelial cell count between the two periods, but donor corneal sloughing was seen mostly in the COVID period due to increase in death to preservation time. Now coming to the treatment outcome post TPK, we defined therapeutic success as the cornea which maintained the anatomical integrity and also which removed the infectious process, and functional outcome as a clear graft or vision with vision more than 660. In both the period, the therapeutic and the functional outcome was similar. Now to conclude, I want to focus on three main points: that as changes were made in the policies of eye banking, such as retrieving the donor cornea even after 12 hours of death, and uses of intermediate and long-term donor cornea preservation technique, we could overcome the challenges of severe shortage of donor cornea. This study concluded that despite operational challenges during COVID-19 pandemic, donor cornea quality and treatment outcomes for TPK remain largely unchanged, and there is a recommendation for practice to include continued monitoring of eye banking policies, enhancing public awareness regarding corneal donation, and pursuing research into innovative practices that can withstand future challenges.
Thank you.
Dr. Venkatesh.
Good afternoon, chairpersons and everyone. Today I am presenting a new collagen cross-linking machine, Smart MNC XL. Keratoconus and post-refractive surgical ectasia is very common, and progressive thinning and bulging of cornea causes visual impairment. So collagen cross-linking is a gold standard treatment to halt ectatic progression. Our objective was to evaluate the efficacy of Smart MNC XL for corneas including sub 400 micron corneas. So the drawbacks of an existing machines are lack of portability, no smartphone control, shorter working distance, no user defined settings. Our machine is a small portable device which weighs less than 700 gram, battery operated, and working distance is almost 70 to 75 mm. Sound.
This groundbreaking device. We are thrilled to introduce the world's first smartphone-controlled collagen cross-linking device, the Smart MNC XL. This groundbreaking device is not only highly portable, but also weighs less than a kilogram, making it a perfect companion for your medical needs. The Smart MNC XL boasts a varying range of intensity from 3 milliwatts to 45 milliwatts, providing you with the flexibility to adjust according to your requirements. With a working distance of 70 millimeters, it offers a larger space for surgical manipulation, ensuring precision and ease during procedures. One of its standout features is a specialized program for corneas with a thickness under 400 microns, catering to a wide range of patient needs. The device also offers a continuously adjustable spot size with homogeneous light intensity, ensuring optimal results every time. The Smart MNC XL is equipped with two types of emissions, continuous and pulsed, giving you the freedom to choose based on your specific needs. Being battery operated and attachable to an existing microscope, it provides unparalleled convenience and adaptability. It comes with 7 preset protocols, including a protocol specifically designed for corneal thickness below 400 microns. And that's not all. The Smart MNC XL also offers a user-defined protocol where you can adjust light intensity, emission type, and duration according to your preference. Experience the future of collagen cross-linking with the Smart MNC.
So this is how the machine is set up. There is a small microscope attachment, or even a normal trolley it can be attached. It's a handheld small device. This can be fitted to any microscope. So we studied, it was a prospective interventional study done at Matrushri Nethralaya and Nandadeep Eye Hospital, Sangli. 24 patients, 28 eyes, 4 bilateral cases were done with an ethics committee approval. Preoperative assessment, uncorrected, best corrected, corneal shift leg imaging and anterior segment OCT was done. Standard corneal epithelial off technique was performed. Isotonic riboflavin was applied for 30 minutes. Standard accelerated cross-linking for corneas more than 400 micron was done. Customized accelerated protocols for corneas less than 400 microns. Post-operative regime was topical antibiotic with steroids and lubricants. These are the pre-operative images which were done, and anterior segment OCT was done. And once the patient is taken up, whatever required protocol you want, you can set it and start the emission. So this was after post epithelial removal. 370 was the micron, and you can continuously adjust the spot size also. So 28 eyes were treated, 24 patients, male were predominant, 97%, 23 patients were keratoconus and 1 was post-LASIK ectasia. Corneal thickness, 21 patients were more than 400 micron and 3 patients was less than 400 micron. Uncorrected improvement was there, and even best corrected visual acuity improvement was observed. There was a clear-cut demarcation line by 2 weeks time, and no disease progression were followed up by 12 months. Corneal topography showed mean reduction in 1.2 diopter of Kmax, and pachymetry maps indicated no significant postoperative thinning. No significant postoperative complications including haze or endothelial cell loss or infections. This is a postoperative decline. Standard accelerated protocol maintained efficacy in thicker corneas. The presence of distinct demarcation line in all cases by 2 weeks confirms the machine's effectiveness. Visual improvement was there, and our study aligns with the standard CXL while expanding the treatment spectrum to include thinner corneas. Nowadays, our machine has been included by Hafezi's articles, which shows for thinner corneas. Already Hafezi has a CI machine which includes all these protocols. These are the newer protocols which keep on coming and keep on changing, which presently, except one machine, there are no any machine which can have all such things. So our machine has the advantage that it can give 3 to 45 milliwatt with 7 preset and below 400 micron corneas. The main advantage is user defined protocol, wherein which you can adjust the intensity, emission type, continuous or pulse, even you can adjust minutes, seconds and everything, and you get the joules how much is needed. So it's a safe and effective CXL. Customization versatility make it a valuable tool in CXL. Holds promise for broader clinical management including ectasia and infections also. One of the co-inventor. Thank you.
What is the thinnest pachy you did?
Pardon me?
Thinnest pachymetry you did for this case?
325 we have done, madam. And there was no any endothelial decompensation.
With isotonic solution.
Isotonic solution.
What do you mean by pulse treatment? Where do you decide? Like in a phaco, where the only thing is I need to eat up that cataract. I give a burst mode or a pulse mode. Where do you decide how you are going to give a pulse treatment in CXL?
So nowadays, newer treatments are coming with pulse mode actually. So we don't have any really good machine in India to do all such studies. So this machine is one of the things where we can really have very good number of studies.
How do you determine whether you are going for a pulse treatment or a continuous treatment?
So very thin corneas, pulse mode would be a better choice, wherein which we give time for oxygenation of the cornea.
So whether that is going to benefit or like it is going to achieve the purpose of C3R?
Yeah, a lot of studies have shown that pulse mode would be a better thing compared to a normal.
But then what is the pachymetry there where you are going to decide that I am going to go for a pulse mode?
Sir, really we haven't done for pulse with any studies now, but based on the literature we have kept in this machine.
Okay.
Thank you.
Next, Dr. Kiran Kumar. Dr. Kiran Kumar, combined topography guided PRK with CXL in KC long term results. Not there. Next is Dr. Tanu Singh.
Very good afternoon, everyone. So I'll be talking on evaluating contrast sensitivity after collagen cross-linking, key findings from the Spaeth-Richmond contrast sensitivity test. So as we all know, keratoconus is a non-inflammatory ectatic disease of the cornea which causes progressive change in the corneal structure. So keratoconus not just affects the visual acuity, but it also hampers the quality and the higher visual function, of which contrast sensitivity is a very important subset. Now this decline in contrast sensitivity can majorly be attributed to the higher order abrasions that are seen with the keratoconus, where the eye is unable to focus the light properly, more so in the low contrast situation. Now collagen cross-linking, as we all know, is the established technique that is done, or the treatment protocol that is done to halt the progression of keratoconus. It not just helps in stabilizing the disease, but also shows improvement in the visual acuity and helps in reducing the impact of optical imperfections like higher order abrasions and contrast sensitivity. So it was a good idea to see how contrast sensitivity is getting affected post collagen cross-linking. Few of the studies that have been done in the past have showed varied results, where few have shown improvement in contrast sensitivity while few have shown a decrease in contrast sensitivity post CXL procedure. Another important subset that was seen was that most of these studies have evaluated the contrast sensitivity using Pelly-Robson test, which is a chart-based test, and it measures only the central contrast sensitivity. And being chart-based, it is subject to various limiting factors like literacy rate of the patient and also the fading effect onto the charts. So in order to overcome this limitation, we thought of going ahead and doing contrast sensitivity using the Sparks test, which is Spaeth-Richmond contrast sensitivity test, which is an internet-based test, and it does not just evaluate the central contrast sensitivity, but also evaluates the peripheral contrast sensitivity. So the primary objective of the study was to analyze the change in contrast sensitivity using Sparks in patient undergoing collagen cross-linking. Along with that, also to see changes in keratometry, aberrations, retinal nerve fiber layer thickness, VFI, and the tear film parameters. It was a prospective observational case series done at GMCH Chandigarh. So all the patients of mild to moderate keratoconus who underwent collagen cross-linking were included in the study. The parameters were evaluated pre-operatively and then at 3 months post the procedure. The parameters that were evaluated included visual acuity, keratometry readings, retinal nerve fiber layer thickness, VFI scores, and contrast sensitivity was assessed using Sparks, which is basically an internet-based test which can be evaluated on this particular, which can be accessed on this particular website that you see. So the screen is basically divided into 5 quadrants: the central, upper right, upper left, and lower left. And each zone is given a score of 20, so that it contributes to a total score of 100. So the score that you get is out of 100. So all the patients who were included underwent collagen cross-linking using standard residence protocol. So this is the representative image with pre and post CXL pentacam images with their corresponding SPARCS image, which shows a change in the score of 1 in the post-operative period. So 24 eyes of 22 patients were included with mean age of 20 years. 60% of them were males. 22 of these eyes had moderate keratoconus and only 2 had mild. None had positive family history and 6 patients had history of recurrent VKC. Visual acuity remained stable in the post-operative period. Keratometry reading showed an effective decline of 0.5 diopter. Now coming on to the important part, that is the SPARCS score. The total SPARCS score remains stable over 3 months post-operative period. However, if we look at the subsections or the quadrant-wise, the upper right, central and lower right showed an effective increase in the contrast sensitivity. However, the results were clinically, statistically insignificant, but it does tell that probably there is a trend towards increase in contrast sensitivity. Higher order abrasion showed an effective decline of 15%. Rest of the parameters were stable. Now looking at the literature, what we understand is that there is drop in contrast sensitivity just in the immediate post-operative period of around 1 to 2 months, followed by increase in contrast sensitivity that is seen over a period of 1 to 2 years. So the major limitation of a study was a shorter follow-up time of just 3 months. A longer follow-up would have given better results, which would have given more substantial results. Apart from that, small sample size and inclusion of mostly moderate keratoconus were another limitations that were seen. So I would like to conclude by saying that it is important to continue to follow up these patients over a long period of time. Also, a larger sample size would have given us and helped substantiate or give more potential results. Thank you.
Thank you. Thank you for finishing in time, madam. What was the age group of all these patients?
Sir, the average age was around 20 years. All the patients above 18 years were taken. It ranged from 19 years to 25 years.
Okay, thank you.
Dr. Vinita.
Dr. Vinita Marian D'Souza. Visual.
Good afternoon everyone. I'd like to present my paper on primary iris cyst at the pupillary margin, a rare clinical entity. So 35-year-old female from Goa, a homemaker married, presented to our outpatient department with history of noticing black masses in both her eyes. In the right eye, she noticed them since the past 10 years, and in the left eye since the past 4 years. She had history of low vision and involuntary movements in the right eye since the past 3 years. So on examination, a vertical nystagmus was seen in the right eye, which was present in all directions of gaze, with the vision in the right eye measured on Snellen's chart was 6/60 and in the left eye was 6/6. On slit lamp examination, globular masses were seen at the pupillary margin in the right eye from 2 to 4 clock hours and from 6 to 10 clock hours, which occluded the visual axis in photopic conditions. Similar masses were seen in the left eye, which did not occlude the visual axis. The intraocular pressure measured was within normal limits. The patient was then dilated using tropicamide. Both the pupils were seen to dilate to 5 millimeters. And in the right eye, the masses were now seen to, which initially obscured the visual axis, moved away, and there was an improvement in vision from 6/60 to 6/18. A fundus examination done was within normal limits. The patient then underwent an anterior segment OCT, where these masses were shown to have highly reflective margins and low reflective center, which suggested a serous cystic content. Entire systemic evaluation also was done, a blood workup including a blood routine, renal liver function tests, autoimmune and inflammatory markers were done and found to be within normal limits. A chest X-ray and ECG also done was within normal limits. Our review of literature showed that in these patients, the smooth muscles in the iris and in the aorta can be affected. So a patient was then underwent in 2D echocardiography, and a flap was documented in the descending aorta. A cardiology consultation then taken was, patient was asked to undergo a CT angiography. Unfortunately, the patient was lost to follow-up. Intervention was planned in the right eye because of the history of decrease in vision. The intervention plan was NDX cystotomy. So after taking appropriate consent from the patient, 2 shots of 0.9 joules was fired in the in an undilated pupil on the cyst located at 6 and 10 clock hours. There was instant collapse of the cyst with release of clear fluid and few refractile particles seen in the anterior chamber. In 20 minutes of the procedure, there was acute rise in intraocular pressure with the cornea becoming hazy and the pressure rising to 40 millimeters of mercury, which was then managed medically. At a 2-day follow-up, the cornea had cleared up and the cyst walls were seen at the pupillary margin. The visual axis, which was initially obscured, had cleared up and the vision had improved from 6.9 to 6.6. So our review of liver literature was done, where Shields suggested that the cause of these was a failure of closure of the primitive optic cup. Classification, they were classified as primary and secondary. Primary further classified as epithelial and stromal. Epithelial further classified as central, mid-zonal, peripheral and free-floating cysts, with the central cyst being the least common. A familial association was documented by Cohen in 1936 and Ahalya in 2023, and it was suggested that there could be a mutation in smooth muscle because of its association with familial thoracic aortic dissection, iris foculi and livedo reticularis. The main differential diagnosis of this lesion is a iris or a ciliary body melanoma, with the gold standard in investigation being UBM. The complications are mainly due to increase in size of the cyst, including corneal edema, uveitis, secondary angle closure glaucoma, secondary pigment dispersion, and the management is mainly determined by the position, size, symptoms, local extent, growth, complications. And the treatment modalities initially ranged from surgical removal to mitomycin C injection into the cyst to needle aspiration to intercystic ethanol irrigation to laser photocoagulation. So in conclusion, these are uncommon lesions which can mimic an iris melanoma. Screening is required for cardiac comorbidities. Simple OPD-based procedures such as NDX cystotomy can be used to treat the symptomatic cysts, and post-cystotomy rise in intraocular pressure must be anticipated and managed. Thank you. These are my references.
Thank you. Thank you, ma'am. I quickly ask all of the presenters to come for a group photo. I ask Dr. Maskati sir and Basak sir to join us for a group photo.
Next session का रख देते हैं. Cornea, free papers. कब